Good afternoon, everybody. I'm really telling the story about the journey in Guelph Wellington Ontario Health Team to use data to segment our population, and the approach that we've taken to do that, which really does align to the conversation that's been going on in the chat about building chronic disease prevention and management infrastructure across partners within our OHT. So specifically, a little bit about Guelph Wellington Ontario Health Team is that we do have a very high degree of primary care alignment. Specifically, approximately 95% of our physicians practice in team-based models. We have 5 family health teams and 1 community health center, to which the majority of physicians or primary care physicians in our community are affiliated. All of our primary care physicians use the same EMR, albeit they all use unique and separate instances of that EMR. We do have a relatively high primary care attachment rate, certainly not as high as it was pre-pandemic, but relative to some other parts in the province, certainly higher. And we do have many clinical champions for improving data. It has been argued, and it's reasonably argued, that because of the primary care alignment in Guelph Wellington, that perhaps the data approach that I'm about to present may not be relevant for many parts of the province. I would propose that if we look at this map, whereby for each OHT, the segment of each OHT that is attached and in a fit versus attached in other models is approximately half of the OHTs have more than half of their population attached to some team-based model of care. So there is some applicability of this approach across other OHTs as well. So really quickly, our model is one that sees Jane in the center there, her current experience, whereby she has some complexity related to her health and social needs. And by virtue of that, Jane described to us that she has many different care teams. And you can see them all there as indicated by the colored dots around her. She describes them as separate teams that sometimes share information with each other, but not always or not in a consistent way. And that she felt that she had a lot of people in her involved in her care, and that it was quite complex and difficult to keep track of. And despite having all of these people involved in her care, she still didn't know who to call when she was in her most vulnerable moments. And so Jane's ask to us was to please simplify her care team. She said, I would like one care team consisting of providers who know me, who know each other, and who I can contact when I am most in need. So it was with that request from Jane and others like her that we set out on our journey to develop the integrated patient care team model. So this really is the IPCT model, which I'll explain in a minute. The other thing that drove us to this model is that physicians said, specifically primary care physicians said, please don't design a model of care whereby I have different ways of caring for different parts of the same person. Please, in Guelph Wellington, design a model of care that does, as sort of Mike was chatting about in the chat, really build that chronic disease prevention and management framework so that I can care for all parts of my complex patients and not have different ways of caring for different parts of them. So the IPCT model is one in which Jane will experience a single dedicated team of providers who are collectively dedicated and accountable to meet all of her care needs, and Jane is central to that team. In our IPCT model, it might mean integration of in-home care to start. It might mean the integration of different aspects of mental health and addictions care. But we really wanted to use data to say, what does each primary care team need in terms of additional resources that ought to be integrated first to meet the specific and unique needs of the population that is rostered to that team. We recognized that foundational to these teams are relationships, people getting to know each other, working alongside in a dedicated way, and that once they were a part of the single team, caring for Jane and the other patients rostered to the primary care team, they would need to be supported to have integrated documentation, integrated ways and streamlined ways of communicating with each other, and that would require harmonized privacy policies and practices. So our model is one in which that considers condition-based pathways and also moves us up the continuum towards a full population health model, whereby we are considering complexity, so those patients with multiple conditions. And really, again, as was discussed in the chat, the chronic disease prevention and management infrastructure to be able to support patients in a streamlined and holistic way who have multiple conditions. So this is our approach to segmentation, certainly wanting and working to understand the health of our population relative to the priority diagnoses. But more importantly, and the focus of this presentation is really understanding and segmenting our population based on the population health triangle at the primary care physician level. We are using the Pop Health Grouper to do that. And specifically, as I said, segmenting each physician's population so that we can say to those physicians, these are the patients on your roster who are in this high user and medically complex category. And we are going to provide those patients with a more intensive model of care. So it is really about identifying those who are more complex and providing them. So the so what for the physicians involved, because they do have to agree to contribute their data to IDS. The so what is that we will help you identify those who are most complex and provide those patients with a more intensive model of care. The problem for us is that our primary care data wasn't easily accessible, and so we did need to develop a process by which primary care data could be contributed and incorporated with other system level data to make this happen. And so we invested in IDS, which stands for Integrated Decision Support. When we started, we had many partners contributing to IDS, but over the course of the almost 5 years, I guess 4.5 now that the Guelph Wellington OHT has been in business, we have made significant investments in supporting other partners to also contribute to IDS, including several of our primary care partners. I'm not going to go through this slide other than to say IDS and the work for us is to demonstrate the benefits of IDS both at the clinical level. So as I said, if primary care physicians are going to agree to contribute their data to IDS, we have to and have been working to demonstrate that there is value to them in doing so, specifically our ability to identify those who are most complex and provide them with a more intensive model of care. There's organizational and system value in helping us segment and then advance our population health approach. Some considerations is that we do have variable HIC models. So when we are inviting and supporting different physicians to contribute their data to IDS, in some cases it's the primary care team, the FIT or the CHC that is the HIC. In other cases, the individual physicians are the HIC. And so we have to customize and support those agreements based on the HIC model. There are costs associated with both extracting the data from the primary care EMR and for the support of IDS, and obviously privacy is of paramount concern, and we are continually monitoring for PIPA compliance. So this is the fun stuff. A few more slides left. What we have been able to do is take the data contributed to IDS by primary care physicians, and this is super tiny and you don't need to see the numbers. It is all to demonstrate that in the first column of that really tiny graph, we have broken down the population roster to a single family health team according to the population health triangle. So we know how many patients within that team are within each category. We've then been able to say by physician, the patients on each physician's roster that fall within those categories within that family health team. We can say to the physician, and these are the patients. And so we have been able to do a chart audit to validate from the physician and the other primary care clinician team perspective that that patient reasonably fits within that category. Once we validated that the patient is in fact reasonably in that level of the Pop Health Grouper, we are then doing some validation, as I said, and then completing a patient journey map to say who else in our system is involved in this patient's care. So if you think back to Jane and all the people that were involved in providing care for her many disease diagnoses, we can see from the patient journey map the different organizations and partners within our OHT that Jane has interacted with. And then we can reach out to those organizations and say, hey, come for a conversation about the care that we are each respectively providing to Jane. And let's have a discussion about how we can streamline our efforts and provide Jane with that single care team that she has been seeking. Through that conversation with our system partners, we are developing and sharing shared care plans. I won't go into how we're doing that because of time, but the last slide is another example of how we're using information that is contributed to IDS to be able to identify and then support those patients who are likely to die in the next year. So we've used a tool called the hospital 1-year mortality ratio. IDS has implemented it in their system so that rather than each hospital or hospital partner having to implement it into their HIS system, IDS has done it once. And as an OHT, we are able to identify all of the patients who, according to this validated tool, are likely to die in the next year, down to the patient level and their respective primary care physician, and we can support conversations between the clinician and the patient to provide those patients with a palliative approach to care. That is the rapid version of our presentation.